Chapter 18. Chapter 18 is general pharmacology. We've now completed the third section, which is patient assessment. Now we move on to medical emergencies, which is section 4. To start off with medical emergencies, we talk about a little bit of general pharmacology. Pharmacology kind of gets spread out throughout the remainder of the course, mostly through the medical emergencies. But it's a good idea for us to kind of touch on the major concepts of pharmacology right now before we get moving into the other emergencies that may have some medications that we are going to be assisting with or administering to the patient. There's not a ton of medications that EMTs give. A number of medications that EMTs may assist a patient in getting or taking, and maybe even administering certain medications to a peer or yourself. But pharmacology is the study of drugs and medications. There's a few key objectives to touch on. It's a fairly good-sized chapter. A lot of good information in here. There's a multimedia video on oral glucose administration. This would be one of the medications that you would be assisting or you would be administering to a patient. And it's although it's a gel made of sugar, it is not without particular potential side effects or negative interactions. Some core concepts. We're going to list which medications can be carried by you and administered by you. Talk about any other major considerations when administering a medication. Talk about the role of medical direction in medical or medication administration, and then how an EMT can assist in IV therapy. Okay, so depending on your state, and then some of their associated rules will indicate which medications you can or cannot administer. In Iowa, there are a couple of them. Aspirin, and aspirins are typically given for patients having a suspected cardiac event or a heart attack, a myocardial infarction. It is used to help reduce platelet aggregation, so it helps keep clots from getting any bigger. Also has some effect on the inflammation that occurs. Oral glucose. Oral glucose is another medication that you are allowed to administer and carry on your truck. It is a concentrated oral gel of glucose. It's fairly high sugar content in it, but I'll take just a moment here to say, remember, just because a person is a diabetic and unconscious doesn't mean that they have to have oral glucose. It can be fatal for them if you do that. If you take this tube of gel and squirt it all in their mouth and expect them to just absorb it, I'll almost guarantee you that they'll suck some of that into their lung. Oxygen. Oxygen is a definite. You can administer oxygen. It is a medication. People don't think of it that way, but it is. It is the most common medication that we give, one of the best, although it certainly has its limitations as well. In Iowa, we do not give activated charcoal, nor do we in Nebraska. So this is going to be strictly informational. There's tends to be trends in the nation that are suggesting that we shouldn't be giving charcoal in the field because of the risks of airway complications. Bronchodilator inhalers. You may be able to assist a patient in using a bronchodilator inhaler, but you specifically won't be administering or carrying a bronchodilator inhaler on your trucks. And these would be rescue inhalers, so we'll talk a little bit more about that. So prescribed bronchodilator inhalers, these are used for patients with asthma, emphysema, chronic bronchitis, and this enlarges the constricted bronchioles or bronchi of the breathing tubes. However, there are some side effects that go along with it, with heart rate and jitteriness. We'll talk more about those in the respiratory emergencies section. This is not nitroglycerin in this picture. This is a patient with a inhaler and a spacer device. Nitroglycerin is a medication that you could assist the patient with, and if you take a look in your textbook, actually on 429, you'll see example of nitroglycerin tablets and nitroglycerin spray. This is basically the same general makeup as the explosive nitroglycerin. It was kind of found by accident. The guy that was inventing the explosive found that when he was out working in his lab, messing with his medication, or messing with his creation, his explosive, that when he would have chest pain, it would go away as soon as he touched it. So it was refined a different way there for patients with chest pain. So patients with nitroglycerin, they're taken by a patient with a history of chest pain of cardiac origin. Helps dilate the coronary vessels or make the blood vessels around the heart bigger. It is contraindicated for people with low blood pressure or people taking erectile dysfunction drugs, Viagra, Levitra, Cialis, so on and so forth. The problem is nitroglycerin is a systemic vasodilator, so it dilates vessels all throughout the body and mostly around the heart and in the chest. Cialis, Viagra, Levitra, those are vasodilators specific that tend to target the genitals. But if you get too much vasodilation going on, you end up with people with no blood pressure, and that can be a big problem. An epinephrine auto-injector. If you want to stop and take a look in your textbook, they have the same picture in the text. But an epi auto-injector, this is a shot of adrenaline, basically, that the patient is going to get. It is a modified version of our hormone, which is adrenaline, and that is used in people with anaphylaxis, which is a severe form of an allergic reaction, and people with very severe asthma, chronic bronchitis, emphysema, so on and so forth. That is an injector, so it does have a needle in it, and it is injected through the skin for them to start to get some relief of the constriction that's going on. So they have constriction of their bronchi, so it's going to help relax the bronchi. However, there is also a vasoconstrictor in the periphery, so it's going to help constrict some of the vessels out in the edges and tend to make things a little bit more relaxed and open in the core. Can increase the heart rate and can increase the blood pressure, but you can assist a patient with an auto-injector. You don't carry these on your truck. So there's a video on oral glucose administration. So let's talk general information about medications. So each drug is listed by a generic name, and then each drug has at least 3 names, being the chemical name, the generic name, and the brand name. We tend to use the generic name in EMS, and I encourage you to use the generic name. Chemical names are usually about 500 letters long and can be very difficult for people to remember and know those. If you'll take a look in your textbook on 431, that little paragraph down at the bottom of the page, about halfway through it, talks about the names for epinephrine. So we talked about epinephrine. Epinephrine is the generic name, or what every company has to call it by. The company that makes the EpiPen calls it EpiPen. Another company might call it adrenaline. But the chemical name for it, as you can see there, B dash parenthesis 3, 4 dihydroxyphenol parenthesis A methyl aminoethanol. That's fairly long, lengthy, and not very user friendly. So that tends to not get used. Now they may steal something out of it when they decide to make the generic and the brand name, but in most cases we do not use the chemical name in EMS. Generic name, like I said, is epinephrine. If you want to liken this to some of your household products, you may have a box of tissues around, facial tissues. That would be the generic name of them, is facial tissues. and the brand name would be Puffs or would be Kleenex, or that is the brand name. One manufacturer of those put a pretty little name on it so people would know that it's their product. So examples of, say, aspirin. Aspirin is the generic name. Bayer or St. Joseph would be the brand name. Take, for example, a bronchodilator inhaler. They're probably all, the generic name would be, of most of them would be albuterol, but certain companies would call it ProAir or call it Proventil or Ventolin. Those are various brand names that they'll attach to their specific product. Nitroglycerin, you might have a company that calls it Nitrolingual. You might have one that called it Nitrong. There's another company that, when you put it into a brand name of the IV form, Tridil is one that is called. So there's various names that can be attached. So what do you need to know before you give or assist in giving a medication? You need to know its indications, its contraindications, its side effects, and its untoward effects. So the indications of a medication is, when should we give this medication? When is it appropriate for that patient to have that medication? So specific signs or symptoms. So for example, for a patient with chest pain, the indications for nitroglycerin and aspirin both are patients with chest pain of suspected cardiac origin. So if somebody gets punched in the chest and they broke a rib, that is not really an indication for either of those medications. It is of suspected cardiac origin, so when they're having a heart attack. Contraindications are times in which you should not do this. There is a contraindication that's consistent across almost all drugs if the patient is allergic to it. If they're allergic to it, you should probably not give them that medication. Now, we'll take an aside for that for just a moment. Contraindications of or allergies to medications usually should be qualified by asking, okay, you said you're allergic to this, what does it do? I get this one fairly frequently. Oh, I'm allergic to morphine. Why? What does it do to you? It makes me feel goofy. That's what morphine's supposed to do. That's not an allergy. People that are allergic to a medication break out in rash, get short of breath, their tongue and face swells up, they get wheezy, they have a hard time breathing. That is an allergy. So that is when you have to be terribly concerned that this is going to be a bad outcome if we give that medication. But like I mentioned in the nitroglycerin patient, the contraindication for nitroglycerin would include low blood pressures. Side effects, some things that might happen. We'll stay on that nitroglycerin concept. It is a considerable side effect of nitroglycerin that their blood pressure will come down. So sometimes our side effects and our contraindications are the same thing. Sometimes it also will give a patient a headache. So, and then untoward effects. Sometimes we have things that are unexpected and can potentially be harmful to the patient, but sometimes things will actually have an opposing effect. So we'll take, for example, Benadryl. Benadryl is something that a lot of people have around the house for allergic reactions. They might take it in the fall and the spring for their hay fevers and whatnot. The usual side effect of taking Benadryl is making you groggy or sleepy. Well, there sometimes is an untoward effect that it actually does the exact opposite, and it makes you hyper and very stimulated. So that would be an untoward effect. Not expected, but occasionally occurs. So medication safety and clinical judgment. When you're going to administer or assist with a medication, this is a serious responsibility. Every medication we have, every medication that we carry has risks, even oxygen, even sugar gel. Those have some serious side effects that can occur. You need to know the medication. You know what you got in hand. Make sure that it is the correct stuff and that we're appropriate to give it. You got to use good judgment. There are no hard and fast rules when it comes to these. So sometimes you may have to make a judgment call. It says, well, I understand you're having chest pain, but you told me that you take a little blue pill to help you out in the bedroom, and you're not sure when the last time you took that was, but it might have been 24, it might have been 72 hours ago. You're not sure. I think it's not in your best interest that we give you nitroglycerin, because that could potentially kill you, and people have died from taking nitroglycerin and erectile dysfunction medications. Medical authorization. Somebody has to say it's okay for you to do this. In most cases in modern day EMS, it's via offline medical direction. We're not calling somebody and talking to them. We're just using our protocol or our standing order, which says if the patient has chest pain and their blood pressure is over 100 and they don't have any signs of this, they don't have any signs of that, and so on and so forth, then you can consider giving nitroglycerin. So that would be an example of a standing order or a protocol. Online medical control, we're not sure if we can give it or not, so we have to call in on the radio or the phone, talk to somebody, listen to what they tell us to do, repeat it back to them to clarify it, and then consider giving the medication. So offline, remember, is protocol. Online is talking, interaction. So the 5 rights of medication administration, and depending on the school of thought, the book you read, you may or may not have 5 rights. It might be 6 rights, it might be 4 rights, it might be 7 rights, but the 5 rights basically encompass everything that we really need. So those 5 rights of medication administration is, do I have the right patient? Do I have the right time to administer this? Is this the right medication? Did I pick up the right bottle, or did the patient hand me the wrong stuff? Is this the right dose, and am I sure that I'm giving the right dose? And am I giving the medication via the right route? So when we talk about these things, the right patient, does this meet the indications that are given in that med profile? Is it the right time? Did the patient just take a nitroglycerin as you're walking in the door, and we're going to drop another one under their tongue right now? Well, you can only do that about every 3 to 5 minutes. And then they can only have a max dose of 3. So is this the right medication? Did I pick up an inhaler and just expect this patient to want to take this inhaler, and come to find out this inhaler is not a rescue inhaler, this inhaler is a daily maintenance inhaler of their steroid that they take every day? Well, their steroids aren't going to help them. What they need is a bronchodilator medication. Is it the right dose? Am I supposed to give 1 pill? Am I supposed to give 4 pills? How many am I supposed to give? And then, am I giving this via the right route? Sometimes people could get confused. Aspirin, nitro, they're both for chest pain. They both come in little pills. What's the right way to give this? Do I drop the aspirin under their tongue and let it absorb there and then make them chew up and swallow the nitroglycerin? No. They're similar, given in similar situations. However, nitroglycerin goes under the tongue, it's sublingual, and aspirin is chewed and swallowed, or oral. So what would be the potential risk to the patient if each of the 5 rights were not checked prior to administration? One of the biggest things that happens in the United States on a daily basis in healthcare is medication administration errors. And the hospitals have done a great job of implementing strategies to help avoid this. But there's never going to be an end-all be-all of these. There's not an absolute fix to all these things. So if we aren't giving the medications appropriately, we stand a risk to do serious harm to our patients. So those routes of administration. These are some of what you might be involved with in EMS medications. Not all these are things that you yourself are going to be able to do. But we have oral, which is swallowed. Oral glucose and aspirin are oral medications that we're going to give. If you're allowed to give an over-the-counter medication like a Motrin or something, which is ibuprofen, you may, that would also be oral. A lot of you may take home medications that are oral. Sublingual is something that is administered and absorbed under the tongue. whether it's a pill of nitroglycerin or a tablet or a spray of nitroglycerin. There are a few other medications that are given the sublingual route. Inhaled, this is breathed into the lungs. This is going to be your oxygen or your metered dose inhalers, or your puffers as they often get called. That is your inhaled, so it's breathed into the lungs, picked up there. Usually it has something to do directly with making the lungs function better. Intravenous or IV, this is injected into a vein. Not something you're doing as a provider, but if you're working with an EMT or a paramedic or doctors or nurses, you may see medications given that route. Intramuscular and subcutaneous, these are both injections, shots if you will, that can be given to patients with various conditions. IM or sub-Q, your epinephrine auto-injector fits into these categories. It actually can work either way. It usually works a little quicker if it actually makes it into the muscle, as opposed to subcutaneous, which is injected into the fat. The muscles have more circulation, so it typically gets picked up a little bit quicker and moved through the system, as opposed to the subcutaneous, which it relies on a little slower absorption rate. Intraosseous is injected into the bone marrow cavity. So this is a special type of needle that will be placed when the usually healthcare provider can't get an IV. If they can't get that IV, then this needle is in the bone marrow cavity, and the medication can be then shot right into the bone marrow cavity, which has a lot of blood flow through it and can be picked up that way. Endotracheal, this is when a paramedic would place a endotracheal tube, or they are intubated, and this tube goes directly into their lungs, and so we can take and spray some medication directly down that tube into the lungs. A couple of other things to consider. Pharmacodynamics. This is the study of the effects of medications on the body. So what is it that that medication is supposed to be doing for this patient? Is it something that this is going to help us make some decisions on what to expect. What effects will it have? Does patient-specific factors change how the medication works? So if we have a patient that maybe is extremely sick, they may have something that's called acidosis, which their pH of their body is very acidic as opposed to the normal basic level that it is. That can change how certain medications respond in the body. If your blood pressure drops very low, medications that are injected subcutaneous or IM may not fully be absorbed, or may take much longer to be absorbed than other medications via the IV route. Weight and age related. Again, it's kind of typical for Benadryl, for example, to make kids hyper and make adults sleepy. Weight-related considerations. Some medications have to be based off the patient's weight. Typically, pediatric medications are almost always weight-related. So there will be a certain, depending on the size of the patient, a certain amount is given per kilogram or per pound for that patient, so it does not overdose them, because giving an adult dose of a medication could potentially kill a child. Certain medications are very weight-based specific, and so they have to be cautious even at the adult that they get a weight that is accurate, so they can dial up the dose and make sure that that patient's receiving a therapeutic level of the medication. Reassessing your patient. After administering a medication, you must reassess your patient and see if it did what it needs to do. Now, understand, there are some medications you're not going to see any effect. You're not going to see anything change on the outside of this patient. Aspirin, for example, in the short amount of time that we deal with a patient with aspirin, or that's been receiving aspirin, the likelihood of them seeing any of us being able to see any sort of change is minimal. However, nitroglycerin, that's fairly fast acting. Within a minute or two, you should see something happen. Epinephrine is the same way. Oral glucose might take 3 to 5 minutes to see anything happen, maybe even longer than that, because it takes a while for it to be absorbed. So bronchodilators, those can help within a matter of minutes. But then again, they may not. And then we may see patients actually get worse. So you need to clearly document the medications administered. Who did it, what route, basically covering your 5 rights when you can, the times that it was given, and then any response that the patient had. Okay, medications patients often take. When we're talking about this, we got to understand that there are thousands and thousands of medications out there. There is no way that any EMS provider, paramedics included, are going to completely and totally know all these medications. I would suggest that providers consider finding some resource, whether it's a little book or a phone app, that will help you in the cases in which you run across medications you're not familiar with. If you guys use a tablet or iPad or some sort of a tough book or laptop on your calls, that may also be an appropriate place to find some sort of resource. Because of so many different meds out there, it's going to be very difficult for you to know exactly what everything uses. Here's an example of an Advair discus. This is actually a type of an inhaler, if you're not familiar with it. This is not one that is considered a rescue inhaler. So this would not be a metered dose inhaler that you would give to most patients that have problems at home with difficulty breathing. So being able to look this up, you could probably see that, oh, this is a daily maintenance medication as opposed to an acute rescue inhaler. And that's why some of that is important for us to have. As we talk with patients, we get their medications from them, we may ask them, why do you take this? And we may or may not get a real story. They may not fully understand why they're on medications, particularly, say, some of the elderly population. They may not know why they take that medication, and they may not know specifically what condition they have that's related to that. If you are familiar with certain types of medications, or at least have the skills to look one up, it can help you in determining what sort of patient history did this person have. If they have 2 or 3 inhalers at home, but can't tell you anything about their condition, it's probably relatively safe to assume that they have some asthma or some other breathing problems to go along with that. Same thing with nitroglycerin. Nitroglycerin around the house. In many cases, you can pretty safely surmise that it is a cardiac history that they may have, and so on and so forth. You will start to recognize patterns when it comes to medication names and so on. In your textbook, there is on 436, there's kind of a chart, or I guess it's a chart, that gives you some of the common medication names that you might hear in some of the classes. There are hundreds of drug classes, though, so the 7 of them that they have listed here is just the tip of the iceberg, and a lot of these have subclasses that are underneath them. So like I said, you'll start to recognize occasionally some of the trends in names that people are taking certain types of medications. If you look at antidysrhythmics, there's a couple of medications in there, propranolol, and then carvedilol, which is in the second column, and metoprolol. All of those fall into a class of drugs called beta blockers, and these are actually most commonly used for patients with high blood pressure. So recognizing some of those key little components of some of these drug names can help you get an early jump on what this patient's taking. Skip down to the bronchodilators. We have the same sort of thing that's happening there. Albuterol, metoprolol, salmeterol, and levalbuterol. Those all, it sounds like the OLOL drugs up above, but it's not. The ROL drugs, ROLs, and the NOLs, NOLs, those are bronchodilators. They're usually beta agonist bronchodilators that will help the tubes in the lungs open up. And the same sort of thing happens with a lot of other medications. So you'll hear things, the codones, the morphines, acetaminophen. Sometimes they have relative drugs that will sound very close to those. So picking up on those is helpful. Knowing the most common medications that you run into. So if you're seeing the same medications over and over again, it's probably a good idea to sit down and study them a little bit on your downtime so you have an idea of what the patient's got going on. In this day and age, a lot of people are using complementary medicine, and part of that complementary medicine includes herbs and supplements. And so there are some reasons why certain people would take these medications. It's listed here on the chart on the screen or in your text on 437. But also understand that a lot of times when we have traditional modern medicine and we mix it with complementary medicine such as herbs, we may not get the benefit that we were looking for. There can be a lot of interactions. Drugs, even modern medicine drugs, will have bad interactions with certain other things. Take, for example, the erectile dysfunction drugs and nitroglycerin, bad interactions. You can see the same thing with your herbal agents as well. And then people who doctor shop, they go to multiple different doctors or multiple different healthcare professionals. The healthcare professionals often can't communicate back and forth, privacy and whatnot. That can make things very difficult to make sure we don't have medication interactions that are going to occur. So assisting with IV therapy, while you cannot start an IV as an EMT, you may be working with an advanced EMT or a paramedic that is going to, and they could use some assistance with you. So heparin or saline locks. Heparin is an older term. We used to use a medication called heparin most of the time to place these IVs. Anymore we replace it with saline, which is basically salt water. This is a catheter placed into a vein with a little lock or cap over the end of it. It keeps blood from coming out. We inject it with some saline to keep the blood out of the catheter, to keep it from clotting off. It's usually used for medication administration. If you look on 437 in your textbook, there is an example shown in the picture there of a saline lock. It's just you can see the little bit of the catheter in the window of the little white, it's called a vein guard, and then the cap that sticks out there that they can inject a needle through. We have the traditional IV, which is the bag that hangs above the patient, constantly flows fluid medication to the patient. The way that this all works is there's that bag of fluid, a clear plastic tubing that goes down from the gravity-dependent bag to the patient. There's a couple of major parts of it to be aware of. The drip chamber, if you look on 439 in your textbook or 440 in your textbook, you can see some representatives of the drip chamber. On 439, the EMT has his right hand over the drip chamber. It's that clear part that you can see through, the bigger clear part. And if you look on to 440, the middle picture there, you can see that there's fluid in that drip chamber, and that's where we're going to count drops. There's a flow regulator, which is a little roller clamp thing. 440, the third picture, picture 1814, is the flow regulator. You move it up and down to adjust how quick it goes. There's drug and needle ports, in which we can inject the medication into the IV. That basically is just like the saline lock cap. There's a male adapter on both ends of the IV tubing, one that is sharp and is directly connected to the drip chamber. That's the one that goes in the IV bag, and one that's relatively dull, and that's the one that plugs into the back of the IV catheter. There may be extension sets, which will make the tubing a little bit longer. To set up an IV fluid set, we're going to make sure we have the right bag. Usually the paramedic will tell you what he wants or hand it to you. You need to look at it, make sure that it's clear, make sure it's not leaking, make sure it's not expired. Right up underneath his right thumb there is an expiration date. Looks like it's something 2011, so obviously today that would be expired, but probably when they took the picture it's fine. So you're going to take a look at it. You're going to pull the little cap that protects the end of the bag off of there. Take the sharp end of the tubing, kind of twist it up into the bag, fill the drip chamber by squeezing it halfway, and that'll allow the fluid to start running into the set. So there's the sharp spike end. That's the end that's going to be twisted up into the bag. There's a cap over both ends. The caps are to help keep it clean. You don't want to take the cap off and then throw it on the floor or lay it on the counter. If you are going to set that down, you need to make sure that the cap is over it. So once you have spiked the bag and you have some fluid running now down through the tubing, you're going to open the clamp all the way up, which means roll it all the way to the top. It's going to allow the air to drain out of that tubing and fill or be replaced with the fluids. Once you have gotten all the air out of the tubing, you've purged the air from the tubing, then you can clamp it back off by rolling that roller all the way back down, and then you have it set up. Talking you through there, clamping it back down. So if you have to maintain an IV, this can be done in certain states with additional training. You can trouble flow some problems. Make sure that the constricting band, which often gets called the tourniquet, doesn't get left on in place. If it stays on, the IV won't flow well. Double check the fluid regulator. Clamped, is the tubing clamped? Is the tubing kinked? Is it pinched? Is it under a backboard? And then adjusting your flow rate properly, you're going to need to move that roller clamp up and down. And then you've got to monitor the IV site for infiltration. Is it swelling? Is it becoming painful? Is it getting red? Those are some signs of inflammation. All of these items are really not specifically appropriate for the EMT at this point in their career. It might be something that your state allows you to do on a basis after you're licensed. That's just kind of a real brief taste. So chapter review talks about the various medications you may have on your ambulance or assist your patient with. You may have to have permission in the form of medical direction to do a lot of your medication administrations, so you have to know what your protocols are. Find out what medications your patient might be on, and then get your sample history. Know what the allergies are. The main purpose in finding this out is to report this information to the people that you are going to hand the patient off to. You may also have to report some of that to medical control if you are going to ask for orders. EMTs can administer aspirin, oral glucose, and oxygen as part of our patient care. Don't do activated charcoal in Iowa or Nebraska. EMTs can assist with respiratory medications, nitroglycerin, and epi-auto injectors, as well as some over-the-counter medications. You need to fully understand your medications, know the names, know the indications and the contraindications, side effects. Know the 5 rights of medication administration. And remember to reassess and document the important elements of that medication administration. So things to have to consider when you're going to give a medication. Should I give it? How much should I give? Where can I get more information about it? What are the necessary steps that have to occur during and after a medication administration. So you have a patient that's complaining of chest pain, and here's some nitroglycerin, says a family member, give him that. What do you do? If the family gives you a bottle of medication, you still have to run through the same steps as you would to administer medication. Do you have a protocol that allows it? Do you need to call in? Do you need to check, is the medication expired? Is this even really the true medication that the patient's supposed to have? A lot of this responsibility is going to fall onto your shoulders. So even though somebody handed it to you, says, oh, it's okay, go ahead and give it, if you're the one that actually gives it, you're the one that's responsible.